Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Inside the Issue. As today we talk about the integration of ALK-targeted therapy into the management of localized non-small cell lung cancer. Of course, we're talking about the ALENA trial. We have a great faculty today, Professor Solange Peters from the Lausanne University Hospital in Lausanne, Switzerland, and Professor Ben Solomon from the Peter MacCallum Cancer Center in Melbourne, Australia. We also recruited several other investigators to participate in a survey that we're going to show you later of their usual treatment practices. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room and we'll talk about as many of these as we have time. For all of our webinars, we put a 1-minute pre-meeting and post-meeting survey in the chat room. If you take that, we'll learn a little bit about you and you'll get a little more out of this meeting. We know a lot of people end up listening to our webinars, particularly on replay. If you're into podcasts, check out our Oncology Today series, including a recent program with Drs. Gaynor and Recamp on non-small cell lung cancer. We're actually, for the first time since the pandemic, going to take a few weeks off from doing webinars, believe it or not. I don't know if I can get used to it or not, but we'll be back in August talking about, we'll probably get into this today too, HER2-targeted strategies. Now we talk about in every solid tumor. We'll see what's going on in terms of colon and GI and upper GI in particular, TDXD, tucatinib, etc. Then we'll be doing a program on neuroendocrine tumors, something we haven't touched base on in a while. It's be interesting to see what's going on there. We'll be heading out to the SOHO meeting, doing a program there on CAR T therapy in non-Hodgkin lymphoma and CLL, and also a program on diffuse large B-cell lymphoma. But here today, we're going to talk about really one of the great advances in lung cancer that occurred this past year. We have two of the central figures in the development of targeted therapy to talk about that, and targeted therapy in general, which has become, lung cancer has really been the poster person or the poster field in terms of targeted therapy that everybody looks to. I think you're up to about 12 targetable targets at this point. As we do in all of our programs, we will be discussing the use of non-FDA approved agents and regimens, so check out the package insert for more information. As we do in a lot of our webinars, we don't want to spend a lot of time going through presentations, so we record those separately. I met with each one of our faculty over the last couple of weeks to record pretty comprehensive presentations, going through a lot of data, a lot of cases. We picked out a number of these slides to really get into some of the themes behind that. And that's where we're heading today. But I just want to take a breath before we get started. Start out with you, Ben, and just reflecting back on the fact, and here we are, it's been such a great year for targeted therapy. We're seeing more data from the ADORA trial and now the ALENA trial. Just reflecting back for people who haven't been in oncology that long, targeted therapy has really been around here for about 20 years. EGFR tumor mutation was discovered about 20 years ago. I'm just kind of curious. I know you both were kind of neophytes and getting your career started at that point, but just kind of curious, Ben, what was going on around that time? One of the things we were hearing about were these sort of Lazarus responses of people who were getting gefitinib, and nobody really could explain it. Any thoughts about, sort of how we went from there over the next few years, looking at EGFR and then ALK?
Yeah, thanks, Neil. It's been a pretty spectacular 20 years in lung cancer, and as you point out, it was 2004 that EGFR mutations were identified, and we were lucky enough to be doing a phase 1 study with gefitinib at the time, and people all around were seeing these amazing responses, and we didn't really understand why that was happening until the groups from Boston and New York described the EGFR mutations, and that was sort of a penny drop moment. This makes sense. And then in 2007, ALK gene rearrangements were identified, and it was a bit the other way around. We now knew who would likely benefit from ALK-targeted therapies. And when the crizotinib trial was on, we were able to direct those patients onto crizotinib and saw exactly the same thing happening with these dramatic responses. And now we're seeing these changes that were of benefit for patients with advanced disease being translated to early stage disease. So it's pretty cool, I think.
Definitely. So, Solange, curious about your thoughts and experiences. I think a lot of this, imatinib had been out there only a few years at that time. Everybody was all excited about that. It was, I think, really the beginning of targeted therapy. Curious what your thoughts were as sort of ALK came into play, Solange. I guess one of the things that I remember hearing a lot was people were so struck by brain mets with ALK. I think that was really striking. Any thoughts about what was going on there as you first started to encounter these patients and realized a little bit about what was going on?
We were very modest in the early days of the ALK inhibitors development, and we were, like Ben was telling, more knowledgeable about the disease than the GFR, starting from the disease, building on identifying and improving the inhibitors, and not just building on a kind of a spurious results found from all comers, I would say, trials. So ALK, we knew very fast, right, in the trial, the problem of the ALK disease is propensity or developing quite fast resistance mechanism to the first drugs we had. Remember, crizotinib, we were very modest, 3 months benefit in PFS as compared to chemo. It was a revolution, but 3 months, which is quite, I would say, at the time being disappointing based on the new standards we have been developing. But more importantly, these patients were developing brain metastasis. 70% of them, 80% of them in the course of their disease. So we were very far from being able to really action on this specific disease, which was, by the way, more and more described. And I think the pace of development of first, second, third generation of ALK-TKI has been absolutely impressive. So from knowing the problem, it was addressed. Going up to alectinib in the adjuvant setting or lorlatinib in the advanced setting, right? We have kind of taken the problem and solved the problem. Of course, we can always do better, but I think the development was very targeted there.
So another sort of paradigm shift that occurred in targeted therapy that I see other people, outside of lung looking at breast cancer and others, Ben, was the idea of holding off radiation therapy to the brain and treating with targeted treatment, which is really revolutionary. I think in the beginning, people really, and we're so used to, running to get the radiation oncologist. And again, now we see outside of lung cancer, people starting to think about doing that. Any comments about how that evolved? It seemed like it was fairly quick that people started using it. They saw it worked and then, okay, let's go.
Yeah, so I guess we know that radiotherapy, in particular whole brain radiotherapy, is a bad thing in terms of toxicities and particularly long-term cognitive toxicities in these patients who are now living for years. So it really was a big advance when we saw that these TKIs such as osimertinib, alectinib, lorlatinib were just as effective in the brain as they were outside the brain. And we were seeing not just responses, but complete intracranial responses, at least as frequent as you would expect with radiotherapy. So this allowed us to use these drugs and keep the radiotherapy in reserve for later and spare these toxicities.
Maybe beyond oncogene addiction, I'd like to give some credit to our colleagues from radiation therapy, because very often we forget to encompass them in the huge advances we've been making. I remember this time we were trying to give temozolomide or gefitinib with radiation in EGFR mutated with brain lesions, with a median survival, which was something like 3 or 4 months, something like that, with brain disease. And one of the main advances we've been doing is, of course, the TKI. But if you think outside of oncogene addiction, the stereotactic radiation, the radiosurgery, the idea that you can address a very high dose of radiation to up to 20, in the Japanese colleague, 40 lesions in the brain, has completely changed the paradigm of disease treatment. Now patients don't die in 3 months from brain metastasis. They die from the disease, but not specifically the brain disease. And this is also some credit to the radiation oncologists. This is an amazing change in the way we address this problem.
All right, let's jump back into the data that we wanted to review here. First, in terms of biomarkers. And interestingly, when we asked, this is the results from the survey that we did, included 4 other investigators, and everybody is on board with testing for localized disease, not just for ALK and EGFR, and not just NGS. You can look over on the right and you see comprehensive profiling. So Ben, can you comment a little bit about what the thinking is right now? We really only have data for 2 agents in the localized disease setting. What's the thinking here in being so comprehensive? Maybe getting ready for the future?
Yeah, absolutely. But actually for the present as well. So you're right in terms of adjuvant ALK and EGFR inhibitors. But we're also in a world now where we're using neoadjuvant chemotherapy and immunotherapy. And we know that this approach is going to be of less benefit in certain populations, including EGFR and ALK patients. So I think there is a case for testing all early stage cases, at least at a minimum for EGFR and ALK, and ideally with a broader panel to encompass other actionable mutations.
So Solange, these are some slides that you showed, and really recommend the audience to check out your talk in detail. But what I really wanted to focus on is, sort of breaking down the mutations. I know in this slide you talk about ESCAT, or I guess targetable mutations. You categorize them based on, I guess, responsiveness to targeted therapy. Any comments? And also where we're heading on the right is all new targets or markers.
The idea of the SCAT, it's an actionability scale. So you quantify the actionability of each target. So it really shows up or pops up which are the targets that you need to look for, because you will dramatically change in an evidence-based manner the fate of your patient by giving a targeted therapy. So the SCAT1, the first tier and the second tier are really to be tested, right? Of course, in early disease, as you said before, it is EGFR and ALK. But I'm quite convinced that the paradigm will extend beyond. But this is for advanced disease, and you have the SCAT. Just one thing, maybe a little negative point here, is your survey is wonderful because you look at academic centers with key opinion leaders. If you go to the real world, remember that ALK is tested in Europe in 60% of the patients in advanced disease. So I can't imagine what is the real number of ALK testing in early disease. So unfortunately, we have lots of education, teaching, and also incentive to give to every countries around the world, every center, every doctor, for this panel of genes SCAT1 and 2 to be tested, because it's far from being the case from Europe to the US and I'm sure elsewhere. On the right part of this table, you have the promising biomarker, potential, of course, targets. And it's coming now the problem of antibody drug conjugates. Will we be able to quantify TROP2? Will we decently quantify HER2 in lung cancer to make it actionable as quantitatively assessed? What about the other one, MET, for example? Are we doing it correctly? And all the others to come, B7H3, B7H4, and so on and so forth. So I think there's all of the development that takes place in our center in parallel to the must-do that we have. But remember that the must-do is right in your survey. It's right for me and Ben, but it's not right for this doctor who treat breast cancer, lung cancer, GI cancers in small centers, or even alone sometimes as community oncologist. It's complex and sometimes not available.
So I don't know if you want to, I'm not even sure TDXD, whether you want to call it a targeted therapy, but you might, if you do, you might want to add it to that list in terms of amplification. At least here we have a pan-tumor approval for IHC3+. To me, this is one of the most important slides in your whole deck, and I really want you to explain it, because honestly, I hear a lot of people talking about it, but I understood it a lot better when you use this slide, particularly about the issue of the fusion genes like ALK.
Yeah. So the main thing is when you think about NGS, your pathologist will tell you, I have NGS, and you will feel completely safe. My pathologist has NGS. Well, it's not only NGS, because first of all, NGS is not sufficient. You also need immunohistochemistry, for example, for PD-L1. And many of these targets, like ALK and ROS, are usually screened for by immunohistochemistry too. So NGS is not everything. But if you have NGS, and you have an NGS which is looking at the DNA, we will be able to confidently see point mutations. So changes of a single nucleotide, changing one amino acid. But what you will not see is very large chromosomal rearrangement, which can simply be missed by multiplexing your sequencing when you use DNA. So your pathologist has to come to you to say, I have NGS, I'm using an NGS, which is the usual on DNA, but ideally he will tell you I'm also looking at RNA. It's called rearrangement panels or fusion panels, which will allow you to see RET, ROS, ALK, MET exon 14. Otherwise, you might miss something like 30 to 40% of them. So sometimes when somebody tells you, I have never seen a RET or I have never seen a ROS, just be careful about also the methodology of testing. In the old day, we were doing FISH, but FISH is very time consuming. It's counting cells and counting red and the green points breaking apart with the chromosomal break. So people don't like FISH so much, but it might be a plan B too in case. But DNA NGS is not sufficient.
So, Ben, another issue here is tissue versus liquid. And a lot of times, if people have the luxury of both, they do both. But can you kind of compare the two strategies and advantages and disadvantages of both?
Yeah, of course. So the huge advantage of liquid biopsy, looking at ctDNA, tumor circulating tumor DNA, is that it's so easy and non-invasive to get a blood test. You could do it at multiple points in a patient's journey. The disadvantage is that it's not always sensitive. So you can have a mutation there and not necessarily detect it in the blood. So it's one of those tests where if we find something, we can be pretty confident that that's real and act on it. But if we don't find something, it doesn't mean that it's not there. I guess the other sort of area that's looking really interesting with this technology is not just detecting mutations, but looking at minimal residual disease after surgery and potentially using that to guide adjuvant therapy, and even sort of potentially during advanced disease to sort of dynamically modify treatments. And I think we're going to hear a lot about this technology over the next few years.
So, Ben, we have a joke here. We always wait to see how long it takes for the chat room to bring up ctDNA. And actually, as you were bringing that up, Hassan in the chat room brought that up. But also, Ben, Rosanna in the chat room says, would you check for targets in patients with squamous or non-smokers? I don't know if you see non-smokers with, quote, squamous or all squamous.
Yeah, so a lot of the guidelines had talked about focusing molecular testing on non-squamous histologies, and the reason for that is the sort of low positivity rate for actionable mutations. But I think there are certainly exceptions there, and certainly from a sort of clinical and practical perspective, if I have a patient who has never smoked, never or had a light smoking history of their younger, I will always make sure that, and even if they have squamous histology, I will make very sure that they have NGS testing done. And I think we also have to remember that with our biopsies, we are only getting a small part of the tumor, and there can be tumors with adenosquamous histology where you can find mutations. So I think there are certainly certain situations with squamous histology that we should test more broadly.
I'm also seeing questions in the chat room already about chemo in the adjuvant setting, but we'll get to that in targetable situations in a second. Solange, can you talk about, we mentioned the fact that this started out with crizotinib and it just moved forward to second and third generations, a little bit about what we know about the difference between these agents.
Yes. So it's really, as I said, it was a problem-solving kind of development of drugs. You had crizotinib, 3 months benefit in PFS, wonderful trial, by the way. 3 months benefit, hazard 0.7 against platinum-based chemo. So defining the new evidence standard of care frontline. But still, with this problem of seeing the emergence, first of all, of ALK-dependent resistance, meaning secondary mutations of the ALK gene, which was preventing the binding of crizotinib, to make a long story short. And of course, brain metastasis. The pharmacology escape in the brain, because the crizotinib, it was measured in 2 or 3 case report, is not going to the brain. So basically it was addressed. So first of all, you need to design a drug which has a better affinity for the target, meaning that the duration of the effect can be better, and in terms off-target resistance mechanism bypass track, you might delay them. But more importantly, having drugs going to the CNS efficiently and actively, and having drugs also binding or preventing a secondary mutation of ALK. So all of these compounds, from crizotinib to lorlatinib, and I must say it's scaled up, right? It's more and more affinity, more and more brain penetrant. You were covering this mechanism of resistance, leading to this data that Ben presented already orally and published, this data of amazing duration of control of the disease with one drug. So no brain disease and no secondary ALK resistance mechanism to come and to see. So really, I mean, the aim was defined, and to me, the aim is almost reached regarding that, right?
So let's take a look at the survey that we did of the two of you and the several other investigators. And all of you already have been using alectinib, but this is kind of interesting. We asked about where else in terms of targeted therapy the faculty has or would use. We tried to get people to think about this without reimbursement. Of course, there are reimbursement issues. Everybody's already, of course, used osimertinib, but exon 20, nope. ROS1, nope. NTRK, no. In the adjuvant setting, BRAF, KRAS, exon 14. But here's the one little, and we've seen this for a while, really since ADORA, that people start thinking about it with RET. And I think people, you can see, actually would actually treat patients and offer patients that. Ben, any thoughts about that? And any other, highly responsive targeted situations where you think adjuvant therapy is very likely to be beneficial beyond EGFR and ALK?
Yeah, it is so tempting to extrapolate from EGFR and ALK and the experience with osimertinib and alectinib beyond these targets. But we have been burnt before. If you remember, there have been adjuvant trials with gefitinib compared to chemotherapy where there wasn't benefit seen. And certainly for targets like KRAS, where we're in the metastatic setting, we're seeing response rates of around 30%. It doesn't make a lot of sense to me to go straight into the adjuvant setting with that sort of approach. But you pointed out the example of RET, where with selpercatinib, you're seeing very similar responses in metastatic disease and in brain that you do with osimertinib and alectinib. So it's tempting. Fortunately, there is a randomized study with selpercatinib in the adjuvant setting that we'll get the results of hopefully not too soon. That'll be able to allow us to do this in practice. But I think we do have to be a little bit careful, particularly with targets like KRAS, MET, and BRAF, where I think approaches with immunotherapy and chemotherapy still may be appropriate.
So we also were curious about the issue of patients. We asked about the use of adjuvant alectinib, how many people have actually received it. You can see investigators are already using it. But on the right there is something interesting too, which is ALK or alectinib in the chemoradiation setting, a la what we saw with osimertinib there. And you can see Dr. Liu's already treated 4 people with it, but it sort of makes a lot of sense. And now that we've seen the LAR data, I would imagine we might see a lot more. So here's really gets into some interesting differences in terms of stage that I was curious about your thoughts on. So theoretically, we're talking without reimbursement issues. So you could do whatever you want. And so we say, what about stage 1B, who has an ALK rearrangement? And you can see a number of people, including Ben, say alectinib. Ross Camage says chemo followed by alectinib. And Solange, you say nothing. Any thoughts? Well, I'll start with you, Solange, since you're the outlier here.
I'm the outlier because I think what was confusing in this question was the staging system being used. So some of these trials have been done using the 7th or the 8th TNM classification, and now we are supposed to use the 9th. So when I said none, for me, was the stage 3B, not the 1B, sorry, not the one for more than 4 centimeter tumor that was defined for adjuvant chemotherapy, for example, or which was defined for zimonib more than 3 centimeter. But stage 1B for the ACM classification is an N0 disease of less than 4 centimeter. And here, if you use the current classification, it was not covered by the clinical trial. So to make a long story short and not confusing people with staging, I think there is an indication for adjuvant anything. If you have a tumor with a nodal involvement, or if you have a tumor with a very significant size. And for me, this size limit is certainly 4 centimeter and more. We have some data with osimertinib from 3 centimeter, but I think it's a matter of debate. So 4 centimeter and above, or N plus N1, N2. And this was, my none was because in the new classification, it is smaller than Z. You see what I mean? But I think 4 centimeter N plus is where I would define adjuvant chemo and adjuvant alectinib and osimertinib, and I know we will discuss it later on.
So, Ben, the breast cancer people would say, well, first you establish the hazard rate in your trial, and then you apply the hazard rate all the way down to patients who are lower risk than were in the trial, and you calculate theoretical absolute benefit. You look at the downside and you discuss it with the patient. That's very different than the more, basing it on the trial. Any thoughts about whether lung cancer will ever move in that direction? Remember, we had Adjuvant Online, the tool to try to calculate what the numbers were. Do you think that lung is going to, and of course, you've got chemo and IO as an issue. And maybe there's something like Adjuvant Online out there right now that would give you these kind of numbers. But do you think we're moving in that direction, Ben, that maybe lower risk patients who understand the benefit and risk might wish to receive treatment, or do you stick with the trial?
Yeah, so no, I think we're absolutely moving towards personalizing therapy, and I do have a vague recollection of there being a tool with Adjuvant Online even for chemotherapy. And almost certainly it should be extended to targeted therapies. But the thing, Neil, in lung cancer is that patients do really badly. Even patients with stage 1 disease have recurrence rates of 40% or 50%. And in the ALENA study, I'm just looking now at patients with N0 disease. The hazard ratio was 0.19 in patients with N0 disease. So they get substantial benefit. So I think it is a little bit, and substantial benefit both in relative terms as well as absolute terms as well. So I think the math is a little bit different in lung cancer to breast cancer here.
So the other thing, incidentally, about that Adjuvant Online model that was really cool was they factored in non-cancer cause of death, which can, as you get 80, 85 years old, that, the numbers start changing a lot. All right, well, let's move on to 2A. Now we're starting to get into the issue of chemotherapy. And of course, the issue of the fact that in the ADORA trial, these patients could get targeted therapy plus chemo, but in ALENA, it was targeted versus chemo. So we have to do a little creative thinking here, but a lot of people are starting to say chemotherapy first, including you, Solange. What are you thinking? Survival benefit, even though it's fairly minimal. You want to? Do you encourage patients, or you say, I really need to tell you this, but I don't think it's a great idea? What do you think? Ben's not even presenting it, it looks like.
So starting for this component that Ben described so well of high relapse rate in lung cancer, even for the large tumor N0, the idea is to try to aim to cure more of these patients. What allows you to cure more patients? It's adjuvant chemotherapy. We know since a while that long-term cure rate is increased by 5% using adjuvant chemotherapy. Are we all convinced that a TKI can cure and not only prevent relapse, but cure more patients? We are still not sure. It will prevent relapse to an extent which will prolong survival without any doubt. But is it really about cure? Meaning, are these patients completely protected from the disease recurrence after stopping TKI at a certain time? We don't know about it. And we are not really convinced that TKI can cure. So if you have a patient with a high risk of relapse, the traditional chemotherapy improving cure and the wonderful TKI at least pushing back strongly the risk of relapse, you should probably use everything you have. So I know the ALINA trial has decided to compare chemo with alectinib, but I also think that in the community, we would like to combine chemo and alectinib sequentially, meaning that we would almost all start with chemotherapy followed by alectinib. However, remember that it's not what the trial defined. So if you are strictly evidence-based, alectinib alone would be okay. But my feeling is the long-term knowledge is for chemotherapy here. And conservatively speaking, I try to convince my patients more than 4 centimeters, even N0 or N plus, to receive chemo 4 cycles, followed by alectinib, chemo 4 cycles, followed by osimertinib for both ALK and EGFR.
And that certainly is a discussion that you just had. That's the usual thing we hear when we ask investigators. But we actually found 2 renegade investigators here, Ben and Dr. Liu, even with stage 3A, no chemo, Ben. And what are you thinking? And also going back to when the ALINA trial was designed, what was the thinking about why it was? I mean, I guess you could have had a third arm, but then it would have been a lot longer to get the answers.
Yeah, and look, I don't disagree with Solange, and I think it is a knowledge gap, but I sort of frame things a little bit differently in that I think what we've learned from the ALINA trial is patients don't do that well with chemotherapy. I think that's a sort of starting point. So I think our sort of new starting point has to be that patients get adjuvant treatment with alectinib. The thing that's uncertain and for discussion is where does chemotherapy fit in here? Might there be some patients, Solange talked about the patients with N2 disease, for example. Might those patients get additional benefit? We don't know. They may. To me, another question is, when should we put the chemotherapy in? It doesn't make a lot of sense for me to start with chemotherapy and leave your most effective treatment to start 4 months later. So I think those are sort of areas of investigation. I guess, in these answers we have to be absolute, but I'm not sure I'm so absolute in my mind yet. I just don't know, I think is the answer. And I think, we talked about personalizing treatments. I think that's the direction we need to go. And there are trials that are looking at combining chemotherapy and alectinib, for example, and that may be the way to intensify treatments for these patients.
And when we started first doing this, people didn't even want to say how they treated patients. And we really appreciate the fact that, people were willing to say, of course, you're going to individualize it. And, it's not going to be every single patient. But just being willing to verbalize this is really helpful to us. So here specifically, when we asked about chemotherapy and ALK, it just reflects what we've just talked about in terms of ALK, in terms of EGFR. I noticed in the ESMO guideline, they said chemotherapy with EGFR is, quote, encouraged. Chemotherapy with ALK is at the discretion of the investigator. So I don't know if there's a little bit of, maybe because of the design of the study, they changed the wording there a little bit. But let's get into the actual data here, Ben. And this is from your presentation. We talked about the fact that testing is really important in all patients. Let's talk about the ALINA trial again, beginning with the design and the thinking that went into this design and the design eligibility.
Sure. So ALINA was a global phase 3 trial in which patients with newly diagnosed ALK-rearranged lung cancer were randomized to treatment with either standard of care therapy, which was 4 cycles of a platinum-based chemotherapy, and the chemotherapy that was usually given was cisplatin pemetrexed, because we know that pemetrexed seems to be a bit more active in ALK-rearranged patients. And the investigational arm was alectinib for 2 years. Now, this is different from the design for the ADAURA study. In the ADAURA study, patients with resected EGFR lung cancer had chemotherapy and then were randomized to osimertinib or placebo. And the duration of the osimertinib was 3 years as opposed to 2 years. So a couple of differences in the design. The endpoint was disease-free survival. And in terms of patient characteristics, I think they were generally balanced. But I think a striking thing for me in the patient characteristics, Neil, was that half of patients had N2 disease, and this was unexpected. These were patients who had, went up for resections, and maybe speaks to something about a difference in the biology of early stage ALK rearranged lung cancer compared to tumors without ALK rearrangements. And I think this will be something that we'll be learning more about over subsequent years.
So Solange, getting back, I was just going to mention to Solange in terms of testing. One thing I noticed here, there are a lot of former smokers and current smokers here, like a third, more than a third of the trial. We were talking about when, EGFR was, picked up and discovered. There was a period of time where people only were testing non-smokers. And here, you see quite a few people who previously smoked. And also, obviously you see almost all non-squamous, but getting back to that earlier question, Solange, a few squamous or called squamous. Any thoughts about it? It's really the face of disease presentation, I guess, Solange.
It's a wonderful question because it's a reminder we always have to do, for example, with all our young doctors or with other colleagues who are not used to treat this lung cancer paradigm. If it's what you really have to look for an oncogene alteration, if you have a patient who have never smoked and has an adenocarcinoma, because you have really a very high probability, a positive predictive value of finding an oncogene. The adenocarcinoma per se in a smoker patient doesn't exclude at all that the mechanism, the oncogenic path, is not through the smoking and the additive mutations, the addition of mutations over time, but is just the bad luck of having an oncogene addiction. So what I mean by that is you should never renounce to do the whole panel, which is done for non-squamous non-small cell lung cancer, depending on your smoking habit. But this trial is showing you that 60% plus of the patients with ALK-positive disease are never smokers. Right, when you look at other trials, the never smoker patient represent 10 to 15. So of course, way more, but still, being a smoker doesn't prevent the bad luck to come to you and to drive a cancer, not through the smoking habit, but through one of these oncogenes. And it's quite interesting for the anecdote. We went to write the ESMO guidelines in Asia. We do Asian adapted guidelines. And our colleagues from Asia were stressing the importance for them to test for EGFR in squamous because they see a certain number of squamous with EGFR. So you can really see that depending on the prevalence and incidence, suddenly even your testing goes beyond. And at the end, we have let it open and we proposed to test squamous because they really insisted on the fact, probably due to mixed histology, but whatever, they find squamous with oncogene addiction. So it's really important to test probably a little more than you would think than the other way around, right? It's better to test too much than not to test somebody who can have these wonderful options as a treatment.
So Ben, last fall we were doing a program on prostate cancer, and Matt Smith from MGA showed a graph similar to some of the graphs we're going to look at right now in prostate and called it a pelican graph, with the idea you want the pelican to open its mouth, and some of these, you've got some serious mouth opening. This is the overall results. Why don't you go through what was seen there? Really striking and very reminiscent, of course, of what was seen in ADAURA, maybe even better.
Yeah, very similar to what was seen in ADAURA. So the analysis of the study had two components. Firstly, in stage 2 to 3A disease, and then in the entire population, which additionally included the 1B population. And results really were very similar in both populations. Wide separation of curves, hazard ratio of 0.24, looking at absolute survival, absolute difference in disease-free survival of 88% compared to 53% at 3 years in the 2 to 3A population, and really benefits seen across all the different subgroups that we looked at. The median disease-free survival hasn't been reached with alectinib, but was around 40 to 44 months with chemotherapy.
Yeah, that 1B, that's a pelican-looking graph there, hazard rate of 0.21, really obviously tremendously exciting. Any comments about these other subsets, particularly, I guess, CNS disease itself was significantly reduced. Hazard rate of 0.22 of CNS disease, incredible.
Yeah, so this is again something that is in common with the ADORA study. We know that patients who have resections of early stage EGFR and ALK lung cancer do have a propensity for recurrence in the brain, and you know that's clearly not a good thing for patients. And having treatments that effectively prevent this from happening is really important. And we've seen it with osimertinib, and we're seeing it again with alectinib, that there's a reduction in CNS recurrence, which is not just a plot on a Kaplan-Meier curve. It's something that's really meaningful for patients.
And here's the actual recurrences. What about post-recurrence therapy? I see quite a few of these patients got ALK-directed therapy afterwards.
Yeah, so when people are looking at studies of adjuvant therapy, and particularly looking at parameters such as overall survival, ultimately there's a lot of interest in what happens to people after they recur. And I think it's really important that these patients get patients on both arms get the most appropriate and effective therapies that are available. And in the ALINA study, although there wasn't inbuilt crossover, as it were, to alectinib, the study was done in settings where there was availability to second and third generation ALK inhibitors. And very appropriately, more than 70% of patients got got ALK inhibitors on progression. The ones that didn't had a mixture of other treatments such as radiotherapy and surgery. So I think there was, at least in this study, very good post-recurrence therapy in the control arm.
So I want to spend a fair amount of time getting your thoughts, and since very few people, even investigators, have had much experience with adjuvant alectinib, sort of how that goes, what happened on the trial. But Ben, can you kind of summarize the bottom line in terms of the major issues in terms of tolerability and toxicity? And then we'll kind of get into both of your clinical experiences.
Yeah, the real summary is that it's really no different to the experience in advanced setting. Very similar toxicity profile. Most patients tolerate it really well, but we do see things like constipation and myalgia that we see in advanced disease, and elevations in LFTs and creatinine kinase. But only about 5% of patients had to stop treatment in the 2 years. There were about a quarter of patients that had interruptions or dose reductions in the 2 years.
Mm-hmm.
So, Solange, anything you want to add to, again, your clinical experience? So what comes up in these patients? How much of an issue is adherence in these people to try to get them through 2 years of therapy? And what kind of myalgias? Can you talk a little bit more about that?
There are maybe 3 points that came to my mind listening again to the wonderful presentation of Ben. Maybe the first thing he stressed, which is also the patient voice. We meet the patients quite often, Ben too, right? Because they are very important for us to build the trials. They always told us from the time of EGFR and osimertinib and now ADARA to ALINA that we don't perceive as doctors how it's different to be disease-free, particularly at the brain level, than having a metastatic relapsed disease, a present disease, which is perfectly well controlled by a drug. It's not the same scenario. In the first scenario, you are still without disease, potentially cured. In the other scenario, you are in the palliative setting. So the sequencing, even if you build in a crossover, whatever, if you can prevent a relapse in a patient who had an early disease, you make him live in a completely different life than if he had a wonderful drug at the time metastatic disease has been diagnosed, particularly when it affects the brain. So second thing is toxicity profile. We discussed selpercatinib, KRAS inhibitor, or whatever other drugs in the adjuvant. One of the conditions we forgot to stress is the tolerability. Because what we know is the adherence outside of clinical trials is probably divided by 2. or way less consistent, right? Then we tried this electronic pills box in Lausanne, right? Looking at hormonal therapy, osimertinib, gefitinib. And it's very interesting to know how many days are missed, right? How many times it's forgotten and forgotten for due reason, right? Myalgia, or even due just to the constipation, which can be very annoying. So I think you can try adjuvant, but you need to have a wonderful drug. I must stress, I'm not so sure that lorlatinib will make the same way in the adjuvant setting because of its toxicity. So toxic profile is very important. Alectinib is well tolerated. The main problem we have is anesthesiomyalgia and laboratory tests. So not the patient telling you, the laboratory telling you that the liver is a little perturbated. But basically, it's probably as well tolerated as osimertinib and maybe even slightly better, I would say. So the last thing is duration. When you embark your patient for osimertinib, it's for 3 years. And when we started to embark patients for 3 years of osimertinib, everybody was saying, 3 years, but it's so long. And suddenly you had Ben presenting the Alina with 2 years. So you embark your patient for 2 years. And everybody said, 2 years, but not more than 2 years? Why only 2 years? So what we need to stress about it is it's difficult to take a treatment for such a long time, for sure. But the ideal duration is an absolute unknown. We have not a clue. Is 2, 5, or 10 would be the right duration for these drugs.
So, audience, fact check me, but I'm having a memory that actually I think adjuvant tamoxifen was initially a year. Then they did a randomized trial of 2 versus 1. 2 was better. Then they did a randomized, actually, I think it was Helen Stewart from the UK did 5 years versus 2. Then I think there was 10 versus 5. Do you think, Ben, or you think you're going to head down that road, or you think you'll be in ctDNA world by then?
I'm hoping we'll have ctDNA to guide us. But yeah, I think you mentioned tamoxifen. I think we've seen something similar with imatinib in GIST as well. So it may be that longer is better, but longer for everyone, I'm not so sure. So I think that's why I'm hoping that we'll have some sort of some sort of clever strategy like ctDNA to guide us.
Ben, Solange mentioned dose reduction. Can you talk about how you approach dose reduction, and do you have any concerns about escape? While the patient's having either from the lower dose or while the dose is being held.
Yeah, so I think it's quite so the standard dose of alectinib is 600 milligrams twice a day. Standard dose, I should say, outside Japan, and I think with myalgia, that can really get in the way of patients' activity, and some patients get really bad myalgia, with elevations in CK. But that responds well to dose interruption. And when you start at a reduced dose, and I would go down to 450 milligrams twice daily, which is 3 pills twice a day, usually it doesn't come back. And our aim is to get these patients to stay on therapy for the 2 years of their adjuvant treatment, or in patients with metastatic disease to be able to stay on therapy. So I think dose reductions are a sort of important and useful tool. In this, the sort of theoretical concern about sort of lower dose and suppression, I think we know from advanced disease that patients on 450 or even 300 milligrams twice daily of alectinib can have good responses. So I'm sort of very comfortable with dose reductions, even in the adjuvant setting for symptoms, for toxicity, I should say.
So this slide from Ben's talk summarizes questions following Melina. We've already talked about a bunch of these, but one I want to ask you about, Solange, that I always think is pretty interesting is the idea of neoadjuvant targeted therapy. I know at one point there was, I think, a trial looking at neoadjuvant EGFR in locally advanced disease, and I think it never sort of took off. Any thoughts about, Solange, whether we're going to ever have neoadjuvant targeted therapy?
Well, the main question mark, biologically speaking, about TKI, and I go back to my idea of cure, if you allow me to say, the main question we still have opened being defining your field for surgery, so meaning defining the extent of your surgical resection or defining maybe the extent of your radiation field. The question is, if you give a TKI and you sterilize parts of your lung, can you consider that the part of the lung where the disease is not visible anymore is completely disease-free in terms of cancer cells? And I'm not sure we have the proof. So meaning that the reason why we would use neoadjuvant osimertinib or alectinib would be because of marginally resectable disease, a very locally advanced disease, where you want to reduce it to do a more minimal surgery. And my main question is, are you really allowed to do it? With chemo, we know you can. Stage 3A, N2, even N3 has been the topic of so many trials. We know you can, but with TKI, it might be that you just render invisible the disease in a piece of the lung that you will let untreated on side. So I think we need data. So to your question, would I use neoadjuvant alectinib or osimertinib? The answer is no. We even had some small series with disappointing result with osimertinib. I would still use conservatively chemo, and of course use the alectinib or the osimertinib in the adjuvant setting. I wouldn't use the TKI in neoadjuvant. There is an ongoing trial, the NeoADAURA, which will look at it, also allowing a combination with chemo in one arm. So it's quite interesting to know what the TKI does, what the chemo does, and what the combination of both does. Until results happen in that trial, I think it's pretty a bad idea to imagine that what we have been learning from advanced disease might apply to the curative setting. Let's be a little conservative there. That's my feeling.
So, Ben, here are several trials that you talked about ongoing. Maybe you can comment on them. I'm really curious about this locally advanced trial and how easy or difficult it's going to be to get people to go on that. But anyhow, can you talk about these 3 trials?
Yeah, sure. So to begin with the locally advanced trial, this is a trial in patients with stage 3 disease treated with chemotherapy and radiotherapy, that then get randomized to either alectinib or to durvalumab, a little bit like the ADAURA study. Again, I think it is. I think it's a really important question. It seems likely that the benefits for adjuvant targeted therapies will extend to this setting, and I think in terms of getting access globally, this trial will be important in this regard. And I think there's a similar study that ETOP are doing with brigatinib, I think, which will similarly be important. There are some other studies looking at neoadjuvant ALK inhibitors, neoadjuvant alectinib, and I think it's really interesting. I completely agree with Solange, but I'd add the added nuance that EGFR and ALK may be slightly different in this regard. With ALK, from the limited sort of experience so far, there does seem to be a slightly higher pathological complete response rate. There's a study in the US called Nautica-1, which has a neoadjuvant alectinib arm, and in an N of only 9 patients, there were 3 complete pathological responses. So I think that's sort of an encouraging signal, and I really look forward to seeing results from bigger series and actually combinations of chemotherapy and ALK inhibitors in the neoadjuvant setting. Because I think we're thinking complete pathological response is something that we really want to see from these studies.
There was some real-world data presented at ASCO and locally advanced with ALK. I think it was like 60 or 70 patients. But even with those few patients, you could see the line with alectinib. It was starting to look Pelican-like, even though it had just a few patients in it. Here's what we've been talking about in terms of tolerability issues. Everybody brings these up. Can you go a little bit more into the issue of constipation, Solange? Do you give your patients any specific advice in terms of diet or medication? How much of a problem is it?
So we've been learning a lot from advanced disease, right? The management of alectinib is really the same in the early disease and advanced disease. What I usually do is I give, first of all, some nutrition and habitudes kind of advices about drinking fibers and general diet. But more importantly, my patients leaving my office with some prescription in reserve from light 1 or 2 types of different anti-constipation classes of drug. Because the patient will probably not call you for that, because he knows he's disturbing you. But as I said before, he might also skip 1 or 2 pills because it's really annoying. So what I mean by that, just prepare the fact that having a contact every time something happens is not easy, particularly not for constipation. A patient will call easier for nausea and vomiting than constipation. So I mean, be preventive. We also have nurses, right, nurse practitioners who will call the patients quite often and really ask for the use or not of this prescription I give in advance. But that's an attitude to take. Same thing a little bit with the rash. Some other drugs give rise to side effects that the patient doesn't dare to call you for that. But you really improve the quality of life if you preventively act for that.
So this is our way of doing a clinical trial. We ask 6 of you questions. If you all say the same thing, then we start to think we're in the right area. And Ben, it's interesting actually that you all kind of estimate pretty significant chance of having to hold adjuvant treatment, and usually because of LFTs. You usually restart at the same dose, Ben, and how long do you usually have to keep the patient off treatment?
Yeah, it's so often the LFTs will improve. Well, the LFTs usually respond quite quickly over a period of weeks when you withhold treatment. I think I will tend to restart at the same dose unless it's a particularly severe elevation of the transaminases, and often for reasons I don't completely understand, you can get away with that. But if it happens again, then I think you've got no choice but to dose reduce. I'm not sure whether Solange does anything similar.
Yeah, exactly the same. And it happens, dose reduction happen quite often due to liver test elevation. In advanced disease, we had this trend sometimes to switch from alectinib to brigatinib, a kind of a decision between switching the drug or rather than reducing the dose once or even twice. But I think in the adjuvant setting, we need to stick to the data. I'm very, I would say, close to that and kind of conservative into that. So we sometimes need to interrupt the first time, and the second time you need to dose reduce. Yeah, it can go very high. It can go very high. Mm-hmm.
Here's one of my favorite slides. If we'd only asked you two, we would have thought there was a consensus. But in fact, you're the only two who said 2 years duration of adjuvant therapy. Dr. Kamage says until progressive disease or unacceptable toxicity. Dr. Schaaf says 3 years of lymph node negative, and you can continue down. Dr. Liu also until progressive disease. So Ben, would you like to counteract what those docs are saying?
No, I wouldn't counteract it. I think we spoke to it a little bit earlier when we said that the optimal duration is really remains uncertain. The best evidence we have is the evidence from the Lena trial, which Solange and I are referring to in terms of guiding our duration, which is the 2 years. I think it is an open question whether longer is better, and I sort of look forward to future trials that address this.
You know, there's one thing which is very important is we always forget, of course, ALK is a conflicting data because of small sample size, right? Is ALK really prognostic per se? Is a stage 2 ALK positive disease having a worse prognosis than a stage 2 non-mutated disease? So 2 or 3 series would say no, and 2 or 3 series would say the contrary. So it's really kind of, we don't know. So basically, we are in the adjuvant setting. We should never forget that some of these patients are cured. So it's always a challenge outside of clinical evidence to tell that you're going to give a drug forever, because some of these patients, unfortunately or fortunately, depending on the strategy you adopt, is already completely cured without your alectinib or zimertinib, meaning that we need more data. And as Ben was telling, probably we need surrogate decision makers, which might be ctDNA, but we need to be guided to go forever with your drug. You need to be guided by your biomarker, because some of these patients have not a single metastatic cell since the very first day after surgery, right?
We could be talking about colorectal cancer here, where they're using it all the time in the adjuvant setting. So it looks like in general, the faculty thinks most people are able to get through the intended duration, somewhat of an adherence issue. interesting. We were talking about neoadjuvant therapy. Both of you don't seem too excited about the idea, but several other faculties have actually done it. I wonder if it's been in a locally advanced situation. I was thinking about that trial comparing alectinib to durvalumab, the Pacific kind of strategy, after having seen what happened with EGFR. So it looks like a lot of people already are thinking about ALK. And Ben, you bring up, of course, the issue of reimbursement, which is really important. This is, one of the issues here is, and I guess in the trial, you didn't see. I don't think at this point you're seeing weird these mutations. Is that correct? You were not able to pick up at the end of the 5 years.
So in the ALINA trial, there's a bunch of patients that I think it's probably a little bit early to say, but I think what we know about these mutations, we probably know more from the advanced setting. And in the advanced setting, what we see is that in patients who, for example, have alectinib in the first line, they have developed mutations like the mutations you see on this slide, like the G1202R. And then when they go on to lorlatinib, they can get these compound mutations, which are difficult to treat. Whereas if you treat them first up with a highly effective drug like lorlatinib, you actually prevent development of mutations. Now, how that goes in the early stage setting, we have yet to find out, because we fortunately don't have that many patients that have developed recurrence after adjuvant alectinib yet.
So Solange and Ben, thank you so much for working with us. I forgot to mention that Ben, it's actually 7 o'clock in the morning, so he's already in tomorrow, as all people are in Australia. But thank you so much for working with us today. Audience, thank you for attending. We're going to take a little break. We'll be back in August talking with Dr. Saab and Strickler about HER2-targeted strategies in GI cancers. Be safe, stay well, and have a great night. Thanks so much, Solange. Thanks, Ben.
Thank you. Thank you. Have a good night.
Thank you.
Take care. Bye-bye.